Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
I am Ashley Ellis. I am the Director of Practice Implementation for the Tennessee Heart Health Network and the Tennessee Population Consortium. I'm also housed at UT Health Science Center on the Memphis campus, and I'm the Assistant Dean for Strategic Partnerships and Innovation there. And I would like to welcome all of you to our webinar today. If you are a pharmacist, today is a special day because we will be offering 1 hour of CE credit. So Dr. Sorensen will be giving us instructions on how to claim that. So that's always a nice bonus for our national speaker. So without further ado, I will introduce our speaker and let him take it away. So Dr. Todd Sorensen serves as the Senior Executive Associate Dean for Strategic Initiatives and Faculty Affairs and is the professor in Department of Pharmaceutical Care and Health Sciences with the University of Minnesota. He's been there since 1998, so he has a long tenure there. He also serves as the executive director of the Alliance for Integrated Medication Management, which is a national nonprofit organization and that supports the widespread integration of team-based medication management services into the care of high-risk, high-cost patients suffering from multiple chronic conditions. So that sounds a lot like the patients that we serve here in Tennessee, and that's really what we wanted to hear from him about and his experience there and what we can take from it to expand into Tennessee. So I will turn it over to Dr. Sorensen and let him tell us about his great work.
Thank you, Ashley. And welcome, everybody. Excited to be here today. So yes, I'm excited to share some of our experience both through the Alliance for Integrated Medication Management and the University of Minnesota today. I'll be wearing both hats, and actually as I go through this, you'll see two different slide templates to show some of the work that was really more based at the University of Minnesota and that work that is tied to AIM. And I'm starting off in my AIM mode today. And these are the learning objectives for this session, listing the key elements of learning and action community that accelerate adoption of healthcare services and produce consistent outcomes. Now, if anybody's a Seinfeld fan, this feels a little bit like maybe a coffee table book of coffee tables that Kramer created, because we are in a learning collaborative here, everybody that's participating in this program, and I'm going to be sharing with you some of our experience with running learning collaboratives and the work that's gone into that. So, and then the second thing is going to use some of that experience that we had in a specific learning collaborative rooted in Minnesota that was a payer and a provider partnership. So it was with a health plan and a group of community pharmacy providers, and extrapolate some of the lessons learned from that that maybe will be useful in broader context. To get started, rooting us all in why this is all important. Of course, I know the work of the Tennessee Healthy Heart Network is broader than just medication use. And so the costs are even bigger, the avoidable costs and that are a function of our healthcare system maybe not delivering the level of impact and value that we would like it to. But just to specifically looking at medication management costs, $528 billion was the most recent analysis that tried to project what are we spending that we wouldn't necessarily need to spend. And this is what we're trying to tackle within AIM and supporting organizations and regions and stakeholders in this work. Because if we break this down a little bit, $528 billion, it sounds like a lot of money. It's hard to wrap our minds around that. Well, it doesn't, maybe we've broken it down into a county by county basis, still a huge number. It's hard to wrap our minds around, but if this analysis is correct, we are spending $175 million in each county across the country annually on suboptimal medication use. We know that we've invested millions of dollars in programs intended to try to resolve this. They have not always worked. We still have this challenge here, as outlined by these numbers. And we know that there's variation in systems and capacities and leadership from region to region. And so this is all setting up for part of what I will describe later on is that an aim, and personally myself, I believe we can have an emphasis nationally on the types of things that might be able to improve this problem. But the real work, the real leadership, and the real impact is going to be done when we organize regionally and do this regionally, because there's so much variability in the way health systems or healthcare services are organized in different communities and in different states. The payer mix, I could go through all kinds of different variables that we've looked at over the years that have convinced us that this work has to be done regionally. And so that's very consistent with what I believe you all are doing in the Tennessee Healthy Heart Network. You're taking a regional approach to tackle a public health issue and coming together and in a multi-stakeholder approach, identifying ways to do that and advance collectively towards a set of goals. So in getting started, and we get into the style in which AIM and work at the University of Minnesota, we've approached this. I wanted to share a little bit about where I'm coming from. It's actually said I've been around for a long time. I've been at the university since 1998. So this has been the area of work for over 20 years for me. And I've learned a lot over that time. These are just some of the experiences. And it starts with, and many here will have likely had similar observations. For all of this time, I've observed multiple efforts, particularly in pharmacy, is where my lens has been aimed, where we've had opportunities, we expand scope of practice, there are payment opportunities in various places, but yet we haven't had the impact. We haven't had the uptake that's consistent with the opportunities that are available across all sectors in the profession, and we haven't had the impact that we would like to think that we should. I had a formative experience working with a national learning and action collaborative that was initially sponsored by the Health Resources and Services Administration and then ultimately CMS, that was really trying to drive adoption of clinical pharmacy services, initially in safety net organizations, but eventually in broader groups than that. And that has really influenced my view of what works and maybe what doesn't work on that. AIM was created to carry on the work of that national learning and action collaborative. And that's what we've been focused on since 2012 when AIM was started. Initially, speaking to the lessons that I've learned, we tried to do this at a national level. And right now our focus is on working with regions to do this and perceive that we're going to have a better impact that way. I'll speak to some of the elements of implementation science that have framed some of my understanding of how we need to approach these problems, and did have an experience over a 3-year period of time co-leading a national study on applying implementation science in comprehensive medication management. So that's informs my perspective. And then this last bullet is where I'll spend some of the time actually going into detail of what that pay for performance collaboration between pharmacy groups and a health plan look like, and the role that we played helping that group accelerate the adoption and focus on improving beneficiary health. So from a conceptual standpoint, personally, and with the groups I work with, we try to bring all 4 of these things together. There's a lot of different strategies, but I have been really interested in the diffusion of innovation theory over a number of years. and what goes into the spread of an innovation and why innovation doesn't spread in certain cases and why it does in other cases, and that there's strategies that we can use to really drive the adoption through that theory. Learning and action collaboratives, implementation science, and then quality improvement in general, and how we use that also as a strategy to measure, create impact, decide where we need to refocus our efforts, and be able to come out of that with not only a quality improvement plan, but then a demonstration of impact. And I often tell this story to kind of highlight where I'm coming from and what was, in part an aha moment, taking us out of healthcare and thinking about what does all this work look like, and really, what does it mean to be in a convening opportunity to try to advance practice and the impact on health. And so this story has nothing to do with healthcare, but when my daughter was a senior in high school, my spouse and I took her to London for a trip, the spring of her graduation. And it just so happened that while we were in London that week, one of her favorite bands, Bad Sons at the time, was playing in London. And she, of course, begged, Mom and Dad, I want to go to this concert. I want to go to this concert. And this concert's out in the outer part of London, a ways, later at night. And of course, I drew the short straw. My wife stayed back at the hotel, and I got to take Alexa to this concert. This is the venue. So this is a band from Southern California. And I'm thinking to myself when I'm there, this music hall isn't that much bigger than maybe a lecture hall at a university or a modest sized conference room in a convention center or at a hotel. And I'm thinking, what is this band doing here? We have Spotify, we have Apple Music. Their music is there available to anybody who wants to listen to it. But this band is in London, traveled from Southern California, and there's maybe 200 people there, 250 people in this room. My daughter's up in the front row. I'm sitting in the back of the room, not really paying attention to what's going on. And I happen to be reading on my phone during this concert a special issue from Health Affairs on the diffusion of innovation and the acceleration of adaptive change in healthcare. And in that moment, I started to think, that's why this band is in London. You can't just put your music on Spotify and expect people are going to find it. You have to create an experience. You have to get out and be with the people who are looking for the experience. And so that evening, in this European tour, which this band that few had heard of, that's what they were doing. And what was the spin-off effect from that? There was only 200, 250 people there, but they were then going to go share their experience with somebody else. They were going to tell their friends, you should listen to this band. Their goal was to create a movement and for it to be an active process, not a passive process. And so it leads me to make the distinction between the diffusion of an innovation and the dissemination of an innovation. And when we know that there are things that we can do better in healthcare, and they've been discovered through pockets of activity, that process of furthering adoption has to be a very active process. The diffusion of innovation theory is honestly somewhat passive. We have to work at it. We have to get out and convene with people. And that's part of the story that you're going to hear when I talk about the health plan, community pharmacy partnership for a learning action collaborative, and really how that wasn't just sitting back and waiting for people to engage. It was getting out and getting them engaged. Just like Bad Sons was getting people engaged in a city that, from my understanding, they'd never been to before until they were playing this little hall out in the suburbs of London. So the diffusion of innovation, as I said, it's been something that has really underpinned my thinking and approaches to how we create change in healthcare, where we focus as the early adopters. That's the group that matters the most. It isn't the innovators. The innovators They will come up with an innovation that might work, but they're more focused on the fact of being an innovator, and they're already on to the next thing of innovation and not worrying about whether or not their original innovation is actually catching fire and moving. It's that group of early adopters that if they don't engage, they are the influencers in this process. And if you get them, if you essentially get to a 16% penetration rate of however you want to measure that in a certain innovation, that then has the opportunity to expand into that early majority and actually turn into something that has sustainability. But it's this group right here that will ultimately be responsible for that process. I'd be curious and interested to learn how that maybe applies in your community of practice with in cardiovascular health, and how the early adopters are potentially the target and driving the acceleration. It's certainly a group that we focus on in our work. If you study this, there's all kinds of things that go into what drives an innovation into adoption and sustainability. I'm really only focusing here on one that I think is most important, and particularly as it relates to why learning collaboratives can work. You would need to create a social system in which there is a connection between those early adopters, and then ultimately between the early adopters and the early majority. All the other four things or three things on this slide matter and are part of it. But the social system is where we have focused on how do we create these connections, whether they be individuals, organizations, or groups, so that we are jointly together rather than in isolation, working to solve a problem. And the saying of a rising tide lifts all boats is certainly applicable here. But what goes into those social systems and how do we bring them together and connect them, and not just be sharing information, but actually co-development, co-pursuit of a goal. So show a little bit about that more in a bit. We bring these three things together of action collaboratives, diffusion of innovation theory, and implementation science. This is what our goal at AIM is. We create purposeful action, achieving intended results, intended being the operative term there. We set that up front. What are the results we're working towards, so that we're purposely working towards it and doing that in an accelerated time frame. So pacing the work rather than everybody's busy wherever they're at. And in many cases, this is a work we already need to do, and we know we need to do it, but there's always something happening somewhere else that can distract us. So how we use the learning and action collaborative specifically to create a focus and to accelerate that time frame on which to go faster than we would if we were working independently. So moving into the experience that we've had in Minnesota, and to highlight an example of what this has looked like for us. And I meant to say at the beginning, if anybody has any questions, comments, reactions, please bring them into this now. We don't need to wait till the end of the presentation. So I could pause here at this moment if there are any questions on that intro and overview. Otherwise, I'll start to introduce you to what the Health Partners Challenge was. So Health Partners is a regional health plan in Minnesota. They are an integrated healthcare provider and a health insurance company. So they have a health system, they have hospitals, clinics, but it's not closed model. They'll take insurance, patients with insurance from any insurance company, nearly. And their health plan is also open. So not everybody who is a Health Partners beneficiary in their health plan needs to use Health Partners. They rely on care delivery through other organizations as well. They had done an analysis in the state of Minnesota for medication management services. Our Medicaid program started paying for that service in 2007. All of the managed care Medicaid plans in the state at that time then had to administer that benefit. Health Partners was one of them. And they came to the thinking that, well, if we're already having to do this for Medicaid, and the state obviously believes there's a value in this, why wouldn't we extend this to our commercial insurance patients or beneficiaries, and ultimately potentially their Medicare Advantage beneficiaries? And so they did an analysis. They did extend this service opportunity and payment for services into their commercial marketplace. And they did an evaluation to determine what was the ROI for that. And I won't go into the details of the methods. Unfortunately, I can't cite a paper. They did this for internal purposes. They've shared it with those of us that have been working with them, but they never published this. But it was their internal analysis and it's driving their internal decision making. So looking specifically in their commercial marketplace, they did adjusted clinical groups. They included total costs, including payment for services loaded into the evaluation, and did match controls. And what they found, and this goes back actually 2012, 2014 was when they did this, so 10 years ago, they found an 11-to-1 annualized savings to them as a health plan. Now, admittedly, that 11-to-1 ratio was with their highest utilizing beneficiaries. They were very high cost members on a per member per month basis. As they extended the analysis into less complex, less high utilizing populations, the ROI became less. But it was always positive. I think that their most expanded application, it was still in the 3 or to 4-to-1. But in this highest risk group, they determined 11-to-1, and then they repeated the analysis a few years later and came to the same conclusion. I think that year was actually 12-to-1 was the RO1 that they identified. So they had this internal belief that paying for this service is actually good for business. It's good for their patients and it's good for their business. Now, there's some things that I think are really important, and this gets to the implementation science implications. We have to know what exactly was the intervention that determined or that produced this ROI so that we can replicate the intervention and produce the same ROI. And often in much of the research that's been done in at least in pharmacy services research, the clear definition of what the intervention is often not well articulated. It's assumed that the intervention is the practitioner, not the service that the practitioner provides. But the intervention is the type of service. And so some of these environmental factors here describe that. In this case, they had defined in their provider network, this is the service. If you will be paid by us, this is the service you must provide. And it was a comprehensive medication management service. So it was, and they were audited. The providers were audited for this. This included this was by face-to-face assessment. There was a level of competency established with the practitioners. The service was integrated with medical providers. It wasn't an isolated service. In most of the service delivery, there was an integration with the EMR, so there was the availability of clinical information. And there was a population management strategy targeting the highest utilizing patients. All of those things matter if we want to replicate this 11-to-1 ROI. We adjust any of those variables, we might get a different result. So I think it was important to highlight where that 11-to-1 comes from, but then we have to think about as we expand the engagement of practitioners in this, how do we replicate these things? So this is their program structure. They have a fee-for-service payment for this service, commercial, Medicare Advantage, and Medicaid. And then they also have a performance-based payment on top of that. And that performance-based payment is related to blood pressure and A1C control, tobacco status, and beneficiary engagement. And honestly, to lower the bar for practitioner engagement, it's not yet at the level of blood pressure control, actually getting the patient to control. It's simply the reporting of a blood pressure and an A1C. And eventually, as the network matures and has the ability to engage in this process better, I would expect the metrics that will qualify for the enhanced payment will change and will become more outcomes oriented, but right now it's more process oriented. And that's on purpose because they were trying to create an easiest pathway possible into engagement. So then they could develop the network to a level that creates beneficiary access and produces the service at the level that will produce the desired outcome. The health plan is actively involved in the population management. So there's beneficiary attribution to the pharmacists. There's a use of CPT codes for billing, and there's a documentation process that's through a continuity of care document that doesn't require proprietary software and is something that can be attached to a claim, and they use a medical billing platform for the claims. Now, the challenge to health partners was in our state, there was a lot of uptake among the health systems, pharmacists embedded in primary care clinics. Most of the primary care clinics at least in the Minneapolis-St. Paul metropolitan area and the larger cities where we have integrated health systems, there is some level of pharmacist integration into nearly all the primary care clinics. So they were the earliest adopters. We were not seeing the uptake in community pharmacies. And what that created was a gap in access for the beneficiaries for a health plan that operates across Minnesota and into Wisconsin and Iowa. There was a beneficiary access disparity. So the goal was, we know this will pay for itself if it's delivered in the right way, and we can get our members access into this service. That's the challenge that they had. So they had modest beneficiary engagement, they had limited clinical impact, and they were not achieving the value, even though they knew that value was there to go get if they could partner with the practice community in a way to produce it. So that's what leads us to what we called slice of pie. The name slice of pie comes from, in Health Partners, that performance-based payment program is called Partners in Excellence. So PIE, and this was a slice of that. They have Partners in Excellence programs for medical care, for dental care, for mental health services, and they have it for medication management. So this is a slice of the Partners in Excellence program at Health Partners. These are all the groups that came together to do the work that I'll describe here. It was led through the University of Minnesota. AIM was a partner in this. We were connected with some implementation scientists at the University of North Carolina, and then Health Partners and the group of pharmacies that were a part of this. We were specifically targeting community pharmacist practitioners because the health systems didn't need the level of help. They were already engaged. They already had infrastructure. Health Partners wasn't concerned about that part of their network. What they were trying to build was capacity through the community pharmacy access points in their region of service. So this was an 18-month learning collaborative. The dates, 2019 to 2021, you'll probably quickly think of what happened right smack in the middle of those dates. So everything that I'll share with you here is influenced by the fact that we were in the middle of the start of the pandemic, 6 months into the start of this work. We created an all teach, all learn environment. Imagine everyone that's here is familiar and participated in that through some of the work you're doing in Tennessee. We had coaching. All the pharmacy participants had a implementation coach assigned to them. We facilitated pacing events every month, and we had some in-person live events, but most of the pacing events were done synchronously, but through webinars. Implementation supports. We had a care process self-assessment that I'll share some outcomes associated with that. We had a practice management self-assessment to help orient the practitioners to this service delivery model that Health Partners was expecting and that we knew could produce the ROI. But in some cases, they were unfamiliar with this. So that was part of the coaching process. And we looked to focus on payer-provider partnerships. So we had that attribution. We had the value-based payment component, and we had the detailed service definition in the audit. So it's part of the things that the health plan brought into this. Our aim, and this was important when we kicked this off, was to improve the individual health and demonstrate reduced patient care costs through engaging at least 1,000 patients in an initial and at least one follow-up pharmacist encounter by December 31st of 2020. We started in really November of 2019. So that end date, we went a little bit longer, but that was the cutoff date in terms of data collection. That 1,000 patients was important. That was intended to be one of those pacing drivers. Every month, the participants in this project received a report of your attribution. Here's the percentage of beneficiaries you've reached. Here's collectively, as a cohort, how close to our 1,000 patient goal that we had. So every month they could see where we stood individually and collectively on achieving a goal. Implementation outcomes that were measured as a part of this, we looked at, and these are terms, and if you're not familiar with them, in the implementation science frameworks. Penetration, we looked at, so the proportion of beneficiaries that were receiving the service that were identified as in need of the service. Adoption rate, so what was the variation across the different pharmacies in reaching their group of attributed beneficiaries. And then fidelity, consistency with the care process and the documentation of their assessment. There were 478 of 1,240 beneficiaries identified, targeted, and attributed that had received a service. And this was measured through the receipt of that care coordination document. So there's a possibility that more than 478 beneficiaries received this service, but we wouldn't know about it and be able to identify it if the provider did not submit the CCD. So there's probably more, but this is what the health plan knew of and where there was likely a claim associated with it as well, with the service. You can see what the clinical indicators here were. Of these 478 patients, 38% of them who had diabetes, 38% of the diabetes cohort had the tobacco status recorded, 29% had the blood pressure documented, and 28% had an A1C documented. So those aren't great numbers in terms of the penetration. Remember, April 2020, it was impossible for these providers to see these patients in person. The pandemic had started, and so one of the things we did as a learning community is we started talking about home blood pressure monitoring. Who's a candidate? How do we find a way to provide home blood pressure monitors? How do we get that information and follow up with patients based on the readings that they're getting? There was this in-the-moment shift in their practice model because of what we were experiencing globally. This is a busy slide. All the numbers are not the key thing here. What I want to highlight is there were 12 community pharmacy groups, not just 12 community pharmacies, different groups. So one of these groups had like 70 pharmacies in it. These are the 4 that we saw the highest performance in. So there was a variability in performance. So this level of adoption of variability is what this slide is really describing. In sites 1, 3, 5, and 9, we had pretty good reach to the attributed beneficiaries. If you look at pharmacy group number 8, you see they had a pretty modest sized group of beneficiaries, and that's the challenge in this. We're working with one health plan. It's a very small subset of their total patient base that they serve. And the group 8 only had 20 patients attributed to them. And probably because of the pandemic and other reasons, they didn't invest the same level of time and energy. They didn't reach any of them. You see kind of zeros across the board. So they were largely a non-participant. But others found a way to adapt their practice and to reach significant numbers. And I highlight this. This is the group of high performers. And we had an event at the university and was part of a broader event that was bringing health plans and pharmacy providers from across the state together to talk about how to accelerate the impact on chronic health. This is the group that not only got paid in the fee-for-service environment, but they met the objectives on the performance-based strategy. And so they were recognized at this event with awards in the Partners in Excellence program, and their groups also received enhanced payments as associated with meeting those metrics. If we move to the outcome of fidelity and specifically the care process, I emphasize that to replicate an outcome, we have to replicate the intervention that produced the outcome. And in that health partner's internal evaluation, it was this comprehensive care management model that they knew that was delivered and produced that outcome. And so with this group, we needed to make sure that they were practicing in that same style. And so they went through some educational sessions to make sure that they were familiar with this. And then we measured their fidelity to the model. It was a self-assessment. It was measured 3 times over the course of the implementation period. And what you can see here is that in every one of the 5 steps of the care model, there was moderate fidelity at the baseline. Their self-recognition as providers is that they weren't necessarily consistently applying this care model with those individuals on which they were directing care. But over time, and with the support of a coach and the educational materials that they received, this increased with each subsequent evaluation. What I think is maybe telling from this is the area in which persistently stayed in that moderate fidelity area is the follow-up and the continuity of care. And if we don't follow up, we don't necessarily know if any sort of clinical intervention we made actually produced the outcome that was achieved. And so there was really an intent to focus on follow-up, admittedly challenged during the period of experiencing the pandemic, not only in terms of patient access, but also the shift in many of these settings to go, once the vaccine became available, spending a tremendous amount of their time shifting into vaccine administration as a part of the public health response to the pandemic.
I see we've got a question in the chat from Amber Grantham, and she's saying, is that a booklet?
This document that's here is, I wouldn't call it a booklet. It's not that big, but it is a publicly available document. And Ashley, I could share that link with you if you want to send it out later. I didn't put the URL for it here.
Great. And when this is posted as enduring material, we can post that link as well.
Great. Okay. Thanks. Looking at the fidelity assessments further, initial assessments, there was 124% of the beneficiaries with diabetes received all 3 of the assessments. Again, that's the smoking cessation status or smoking status, blood pressure, and A1C. 42% of beneficiaries with CVD had the blood pressure and tobacco, the A1C, not relevant in this case. Seeing an increased percentage of beneficiaries with that fidelity, I think it makes sense. You can measure the blood pressure yourself, or if you are using home blood pressure monitor, get that information from the patient. The A1C would have been harder to collect in this case, and even harder because of the pandemic. And that was done on the initial assessments. And looking at those who had follow-ups, again, pretty modest performance in terms of being able to report A1C and blood pressure assessments. Now, one of the reasons that might be the case is if we look at this chart, and specifically we would hone in on these 3 columns. This is what was reported as the baseline for these beneficiaries, health partners beneficiaries, regarding their blood pressure status, A1C, and smoking status. So just in that diabetes cohort, 80% of them already had their blood pressure under control at the time of the first visit. 87% of them had an A1C in range, and 93% were not smoking. I don't know the public health statistics in Tennessee. I can imagine they might be similar to Minnesota. Our population average is not this high. This group of pharmacists, they were reaching a group that was healthier than the average resident of the state or the average beneficiary in the health partner's health plan. Lots of reasons that could be. One is these were engaged patients. That's part of why their health was under better control, is because their level of patient engagement in their care. Because that engagement might have been easier to reach them. So the groups that they reached out to try to enroll in this program didn't respond, maybe if they were less engaged in their healthcare. So the point with this is that to be able to reflect this back to the pharmacists, they would not have known this had we not collected this information and been able to reflect it back to them. They didn't realize they weren't getting to the patient population that needed the most. They might have known it anecdotally by just things that they were seeing in the course of care, but they didn't see it reflected in summarized data. And so part of the next phase of work needed to be, how do we engage those who are not at goal? This was not the population that was going to generate value back to the health plan. They were already pretty healthy. Shifting out of the outcomes and summarizing some of the data, we did also evaluate at the end of this experience, what was the experience of the providers in this? What was it about the Learning in Action Collaborative that they found most useful, most beneficial? By far and away, the coaching was the thing that came out as the most important. Should have said, when we got started, we had an idea of this program with health partners had been in place for 10 years almost by this time. We had assumed incorrectly that many of the groups that were signing up, because they were early adopters, would know how to get credentialed with the health plan, maybe already were credentialed with the health plan, had the infrastructure to submit a claim in the mechanism by which health partners receives it. We quickly found out they did not. They knew about the program, but they hadn't gone any further than that. So we had to help them with the credentialing process. We had to help, some of them had to acquire new IT infrastructure to be able to submit claims and to create the CCD reporting that the health plan required. That went faster and easier because we were all working on it together and that they had a coach than if they were all trying to figure it out themselves. The next item that they described as being beneficial, coaching was the top. These are listed in somewhat of a general order of how they described the impact, was the community of learning. Mentioned the fact that the pandemic started in the middle of this. Having a group of practitioners already connected into a communications platform across different organizations. One of the things they were able to do is work with each other on COVID adaptations. I mentioned the thinking about how to shift to home blood pressure monitoring during the period of the sharpest shutdown. Communicating with medical providers was another area where they learned from each other. How were different groups doing this? And the billing and documentation. We ran pacing events. They found value in those, but they often found it difficult to carve out the time to be part of a synchronous event. So that had value, but less value than the other two components of operating this Learning in Action Collaborative. And then the measurement and feedback, they did describe how that patient care process self-assessment helped them understand where they were and where they needed to get to in terms of fidelity with that practice model. And ultimately what that would mean, and Health Partners didn't do auditing of the service during the midst of this. But they came away from this as providers understanding these are the things we need to do to make sure that we wouldn't have a problem on an audit. Some of the resources and topics that were requested by the group as we went through this, so they were looking for additional billing and documentation resources. They had anxiety about what an audit process in a non-medication dispensing environment might look like. And so to learn about how that would work, how to use the beneficiary risk scores that were being provided to them, and increased frequency of progress reports is a request that was made. So what I take away from this is what we were able to do is we did increase community pharmacy engagement in this. It wasn't a majority of the community pharmacy practitioners in the state or that see beneficiaries from Health Partners, but it was the early adopters. And in AIM's work, we often have a saying is, we're going to work with those who show up and we're not going to worry who's not there. Because if you come, that's the right group to be working with. This was the right group to work with, and they will be the influencers among others over time in the state. We overestimated the practitioner readiness. I mentioned that. They had very little experience with this care model. They had lack of understanding of how to partner with a health plan. They had a lack of infrastructure on IT and workflow. And they had very limited capacity for data management. So they had a lot of growth that needed to occur to form this meaningful partnership with a health plan that was ultimately going to create a win-win. A win is that the pharmacy providers would be able to had an opportunity to be paid for services that operate at the top of their capabilities, and the health plan would receive the value back that they knew they could achieve in these targeted populations. And then the other things I've spoken to already. So if I take a step back then, and that's the slice of pie in the Minnesota example, and I think all of us that were involved with that found that to be a really rewarding and impactful experience, and it set us up for future activities in the state. But it really helped accelerate this way in which a health plan and a group of providers would work together for a common goal. It was not a transactional relationship. This was a value-based relationship. And because of that, the possibility of sustainability is higher. So stepping back to AIM, recreating things like this and working in this space between providers and health plans to find that common goal, to produce that value is what we're focused on, and what we're calling this the RITS initiative, Regional Integrated Transformation Zones. What we did with Health Partners, we couldn't do that with CMS on a national-wide basis. We need to do right now the opportunity to make the fastest impact and the biggest impact in the fastest way is to work at a regional level. And so we design these initiatives and working with different groups. And we're very close to having confirmation of having some funding to be able to work with the Tennessee Healthy Heart Network to do work in this same space. So I'm hoping that we'll be furthering this collaboration beyond this webinar and further with Tennessee, and using some of the things that we've learned in the application of this model. Every region's a little different, so we customize this. We organize regionally. You're already regionally organized in the network. We used evidence-based methods, and we're really focused on action-oriented leadership. Not that a passive process, but really that what do we need to do to bring people together and to initiate and accelerate action. So there's a method and a discipline to this that we have learned over the years, and we apply into the groups that wish to work with us. These are some of those variables that matter. that we have discovered at a regional basis. It's easier to work with a regional health plan than a national health plan than, say, like United Health Group, where they're trying to do something similar across the entire country. So where we can work with regional health plans, we find that we have an easier path to success. Eventually, that'll extend to national health plans, but focusing on regions where we have regional plans who wish to engage in this. The geography matters. My state, 3.5 million people live in Minnesota or Minneapolis, St. Paul. That's over half the population of the state of Minnesota. So 10% of the geography of the state represents 60% of the population. That's different than another state that has more distributed population centers. And the rural access points might look different. We have a lot of rural areas in Minnesota, but most of the state, other than the most northern part, has a fairly consistent population distribution. A lot of small towns rather than a few larger towns. That influences how healthcare is organized. Another factor that's different here than maybe some other states, we went through vertical integration of our health systems 10 years ago. We don't have privately owned, independently operated medical primary care clinics much in this state any longer. And I know that's the trend nationally. And so that is different than maybe working in a different state where that is still present. And how do we organize this type of work to drive change based on what that distribution or organization of healthcare looks like? Scope of practice, limitations, opportunities will impact the way we approach this work. And then in the case of medication management, pharmacists and their familiarity with a consistent practice model. Truthfully, one of the factors is the distribution of chain versus independent or small regional chains. You can usually move quicker and more nimbly working with groups that are independently owned or small regional chains. That's every one of those groups that was in that Health Partners Slice of Pie project. They were either independent owners or they were regional chains.
That was going to be one of my questions. The type of people or environment of people that were earlier adopters. So yeah, that's interesting.
Yeah, I mean, the Walgreens, CVS's, Walmarts of the world were certainly invited. They're just not ready to move into that. And part of that, again, is that national focus. They're not necessarily built to customize and take advantage of a localized opportunity because of the consistency they have built nationally, whereas in the regional chains or in the independent owners, they were able to adapt to this much more quickly. I think we'll eventually get there, but that's where we can have the earliest success right now. We are starting to get some of that chain engagement involved in the state now, because like Tennessee, we have passed a payer parity bill, and so in the commercial insurance business, there are more payment opportunities now. It isn't just one or two or three health plans that are paying. Eventually, they will all have to as of January 1st, 2025. So that's gotten the attention of other groups. Ashley, was there any other follow-up questions to that?
Well, just kind of comment, that would certainly influence the kind of what you were talking about, the infrastructure that they have, what they have available, their ability to make changes with staff and things like that. But, the timing of this project is interesting with it being during COVID because there certainly were changes that the chains made with test to treat, vaccines, the way that they staff. So I think you're right. I think there's opportunity, but it's a slower moving machine.
Well, and I think it points to that power of collaboratives, particularly for those who aren't part of large systems. Large systems can benefit from this, of course, as well, but why was there the higher adoption in the integrated health systems and the pharmacists in primary care? They had the billing infrastructure, they have the IT infrastructure, they have people whose job it is to help create the adaptations. It didn't fall on the pharmacists themselves. They're part of a bigger system. The chains too can build those systems internally and extend them across a number of different practice sites. For these groups that Health Partner was trying to engage, it was all on them. And because it was all on them, and they had other things that they needed to focus on, it was hard to make that decision to engage. But creating the learning collaborative and providing the support structures, that gave them the impetus to engage and gave them the support structure that they needed to move more quickly than they could on their own. I'm near the end here. I just a couple of things again regarding how we approach this at AIM in the RITS initiative. We really break this down, and there's two broad steps that come into play. There's the pre-implementation. That's how we convene different groups. We form relationships. We create a leadership agenda. We explore the common areas of priorities among the stakeholders that are involved, and we find what that win-win is. All of that is pre-work, and we have to work through that first before we can then move into the implementation, because now we've got our roadmap and we can know where we're going. So how do we organize our communities? How do we implement that care model? How do we create the collaborations where then we can start to measure our success and sustain and scale this work? So there is a progression to the way in which we convene groups, and we're never the ones doing the work in AIM. We're the ones helping the community decide how do they want to organize themselves, who's going to be here, what are our goals, and then supporting the group in accomplishing those goals. These are the things that come out of RITSs when they are structured this way. We create new partnerships between providers and plans and potentially other types of entities. We'll see pilots launched. We can then identify commitments when we've got some success starting to build momentum. What are the commitments for moving forward? And then finding out what's the investment that's going to happen here. And that's not only a financial investment, but other types of investment that create sustainability. So that does take me to the end, Ashley. So if there's questions, and I don't know if you wanted me to share the assessment questions that were part of the CE here.
Yeah, if you can go ahead and do that, and then we can share how to claim your CE.
Okay. So based on this, what you heard today, a recognized factor that drives diffusion of an innovation is which of these four? So either money or compensation, reducing regulatory barriers, a social system for adopters, goal setting by adopters. I think they're all important, but in the context of the diffusion of innovation model, it's the social system that is critical. And then the second assessment question, the most valued learning collaborative strategy from our Slice of Pie collaborative was access to printed resources, implementation coaching, synchronous education sessions, or contact with health plan personnel. And we had all of those, and they all had some level of impact. But yes, it was B, the implementation coaching, which unfortunately is also the most expensive thing to provide. But it had a big impact. You get what you pay for sometimes. And here is the CE information. There is a second slide here, but that's for those who will be watching the recording, if I understand correctly. This is for those who are here today.
Yes, so that website there, and I can copy the link and put it in the chat. So you can go to this link, and then if you go to the next slide, this is our code. So there will be one code for those of you who are live, so it's the one with the L. And then those of you who are watching the recording back, do you have that slide, Todd?
That's this one.
Okay, it's the one with the H. So if you're watching the webinar at home, you will do the H, and then if you're here with us today, you'll do the one with the L. So we'll give you just a second to write that down. And we've got about 3 minutes. Thank you, Thea. We've got a few minutes left. We've got about 3 for people. If anybody want to come off mute, you can ask Dr. Sorensen questions about his experience, about anything that you've got going on in Tennessee, questions. We have time for you to ask those. Okay, Amber. Yeah, go ahead.
Sorry, I'm getting there. Hello. So I am at a place right now. I am doing services in a primary care clinic. I'm in the clinic right now because they're giving me the opportunity to get my training in for diabetes education. However, over the last few weeks, been looking into resources of how to do MTM, maybe through outcomes in the clinic. And I have to, as well as obesity counseling, I have to type up kind of a little presentation to the quality services person. I have talked with her, but she loves the idea and she's really preventative care focused. So she has to present information to her two bosses. What would you recommend kind of as a just kind of as a group, like 1, 2, 3, make sure you include these things because it would be an initiation of services in that particular clinic.
So with the short time that we have, because that's a really big question.
Yeah, I know. I'm
And
sorry.
and I can appreciate the nuances that are in it, and some of it are you getting to know the organization itself, but it comes down to value proposition. I mean,
Okay.
ultimately, how you position that, and if you want to connect offline, I can provide you with some resources that I've used to help people think about how they present a value proposition. And often the focus is on the revenue, and of course that's important. But if you really take in the quadruple aim as in addition to revenue, you've got 4 other value drivers that may or may not be important to that organization. So thinking about patient experience, and if there's wait times, and if providers have full panels, that is an area where I've seen driving value that creates an investment from the organization. The provider experience self. We've got data that shows that when you integrate this service with medical providers, it actually improves their joy in practice. And sometimes that is a driver. There's the cost implications, and then of course the clinical outcomes. So thinking about all of those elements in addition to the revenue stream is what I recommend people thinking about when they're building a value proposition, and have to give that pitch to somebody that it sounds like you have an opportunity to do.
Thank you.
Thea Blystone, you're next.
Hi, thank you so much for your time. I greatly appreciate learning from you and learning to see what other states are doing. I'm actually in Pennsylvania, and I do more along the lines of remote patient monitoring and stuff with collaborative practices and things that way. And I just wanted to like kind of pick your brain a little bit about the pharmacist that you engaged with, because it sounded like they were in either ambulatory care or maybe in pharmacies. Was there any interest from any in the consulting space to help with these initiatives? Because programs like mine in the care management space deal with a lot of the quality metrics that move the needles for these payer groups. And so I just wonder, are you seeing a trend of consultant pharmacists looking at this model or helping with these initiatives across the country? Because quite frankly, here in Pennsylvania, I don't see many.
So I can speak briefly to the health partners experience. So again, who's going to have that desire Is it the health system? Is it the clinics themselves? Or is it the health plan? And in the case of health partners, their goal is to reach the beneficiaries that need the service and for which then it's going to generate an ROI. They aren't seeing that uptake across all their beneficiary base. So they are engaging consulting groups or other forms of maybe non-traditional providers that may be more telephonic based. They've got a group that they're connecting with, and in some of these cases, they'll do it on a not a fee-for-service basis, but on a more of a contracted performance-based basis. Right now, I know they're working with a group that's very specifically focused on really complex, high-cost pediatric populations that often fall through the cracks. And the group that they're working with that is not based in Minnesota has a lot of data to show the impact that they can have. So in addition to the traditional access points of primary care integration and community pharmacy, if this is getting to your question, they, as a health plan, are looking for solutions wherever they can find them, and that they believe that the providers are going to help them achieve their goals.
Thank you so much.
Thank you. Thank you, Dr. Sorensen, and thank you, Thea, for joining us from Pennsylvania and sharing your experience. As always, we would love to connect and learn from each other's experience and practice settings. And that will conclude our meeting for today. We look forward to seeing you at the next one. Keep an eye out on the newsletter. If you are not subscribed, please do so. Please go to our website. And you'll be able to see this webinar in about 3 business days. So we'll see you soon, and we'll keep an eye on what you're doing in Minnesota. Thank you so much, Todd.
Thank you for having me. Enjoy
All
your
right. Bye-bye.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.